child care, especially in rural areas, is a problem. You all know that even in Akwa Ibom State, I hope a member is here, that many young women do not go to the clinic anymore. They go to prayer houses. It also happens in Cross River. It happens in Ebonyi. It happens in Benue. Many people go to prayer houses. I didn't say churches. I say prayer houses. And you also know, and with due respect to my brothers in the diaspora, as you know, I'm one of the number of cases. If you run a clinic and you have a Igbo woman who had a previous cesarean section, they will have 5, 6, 7 different antenatal points. If you go this way and say, look, what has happened to you, we may do another, we may repeat cesarean section for you. They will move to another clinic so that they're looking for a doctor who will say, we would give you a trial of vaginal delivery. So they move like Sokugo. Sokugo is a wandering disease. So we in the end, there are so many casualties. If they survive and they deliver themselves, as you all know, it's a stigma in the southeast. If you have not delivered penaturalis, if you have not delivered pevaginum, your colleagues will be insulting you. And you think you are a woman. So they go to any length to avoid repeat cesarean operation. In the end, there may be casualties, and there have been casualties. Shortage of well-trained and adequately compensated health care providers, the JAPA syndrome. When we were talking about this issue of JAPA syndrome, the government of Nigeria, the governments, I say governments, not government, governments of Nigeria did not take us serious. I remember that as a president of Nigeria Medical Association, we organized the first series of annual series, lecture series for NMA, and the issue was on medical tourism and JAPA, and we discussed at length. But in the end, there was no follow-up. They think that we are joking. Now, even house officers, as soon as they finish their house job, they are airborne. There was one time 2 years ago, I was going to, where was I going? I was going out of the country. And one immigration officer saw me. He said, are you also going? I said, no. He said, why are you asking? He said that because every day at the airport, Namda Airport, every day doctors must leave, other health workers must leave. And you can't blame them. If you cannot pay for your school, for your child's school fees, if you cannot feed your wife may divorce you because no wife wants to suffer. So people have to go and labor. They go as laborers. So many of them go as laborers. If you don't know, I'll tell you, because I know many of them who are there as laborers. Others a few of them may have a very good job, but many of them go as laborers. One of my former students who went to Saudi Arabia, after 1 year she came back. I said, are you not going back? He said, no, you cannot go back. So you have to be very careful in the process of JAPA, because when you go and stay for too long, you'll be brought home through the casket. And you don't need to bother. Things are not as rosy as we think, the young ones. In 1987, I refused to stay in UK. I said I will come back. Whatever we are doing, we'll suffer it together. And I'm sure and I believe that my contribution to national development is far, far more than if I had stayed in that place. I probably would have been taken to old people's home now that I'm 70. But in Nigeria, I'm still here. So please, don't be deceived. That place is not as rosy as people think. You go and you can't complain when you go there. Of course, we know that out-of-pocket expenses is a big problem here. And now more than before, because antibiotics that used to cost 3,000, 2,000 is about 15,000. Some over 30,000. How many of our people in the villages can muster 5,000 naira to buy antibiotics? That is where we have problems. And that is why they migrate to where? They migrate to prayer houses. And you and I know that even when, as a Christian, Even when you are giving drugs to your patients, you pray so that it works. You don't leave the drugs and say, okay, pray, it will work. It will not work. That is the truth. Even if you are a pastor here, I can tell you that prayer alone will not work. Even in Bible say walk and worship. So we must be very careful. If you are a pastor, don't deceive your patients. Next. Impact of MCH on economy. Enhance economic opportunities and empowerment. This improve long-term workforce productivity, pursue education and drive growth in their communities, improvement in livelihood. Of course, that is the duty of a good economy, on MCH, and of course contribute to increase national health. You look at this, see, I don't have a point, but if you look at below, you see what economy is doing. Economy is going down during the COVID crisis, and of course we now have a climate change to contend with. Delayed access to health care, and it's worse now than ever before, when nurses and doctors are jackpying by the day. Who is there to give? And then of course we resort to the community health extension workers, who probably are not properly trained, and therefore those are the ones they have. And then of course reduce postnatal care. Many people may not even go for postnatal service anymore. Therefore they may not have opportunity of family planning, counseling, and service. Negative health outcomes, maternal, perinatal, and child malnutrition. And let me talk about child malnutrition. Malnutrition, marasmus, kwashiorkor will be far more in the next 3, 4, 5 years because of the harsh economic circumstances we find ourselves today. And you need to collect data and see, and then review in the next 4, 5 years, and find that there will be many more. We're not talking of deaths now, we're talking about those who would have died, and then those who probably have marasmus or kwashiorkor. It will be more, because even maize, the cost of maize has gone up. The maize, furan denunu, these days you can't even buy anything anymore. On the plateau we used to buy Irish potato. As I am a professor, a gynecologist, I can't buy a bag of Irish potato anymore. So if gold rust, what will I undo? If me at this level cannot buy a bag of potato, how can a villager buy? Where will you get the money to buy Irish potato or acha, which is a common food that we have on the plateau? So we really are in a mess, and I hope that somebody will quickly intervene, because it's not very nice. Restricted healthcare access. Again, limited immunization coverage. I think the Federal Ministry of Health is trying to expand the immunization coverage. How well it is, I do not know. And then, of course, the issue of budget. Budget has been a very problem. And then the budget has 3 components. First of all, we're asking for budget. Yes, if it's improved. Now, how much of this is released? As a DG of NIMA, no, our budget, our small budget, never, the release never passed 50%. Never passed. I have the statistics. Our budget, annual budget release was not more than 50% of the total budget that was allocated. And then, of course, if you have the budget, how well do you use the release? If the release, how well do you use it? Again, it's left between you and I. If you know what is happening now, you will be surprised. Things are so bad. The level of corruption is very, very high. I don't want to name any specifically, but just go to any office and say good morning. The next thing they'll be looking at you whether you have 500 naira in your hand. Otherwise, nothing will work. That is why IPPIS is where we are. For 2 years in my university, staff employed had not been paid because of the convoluted corruptive tendency of the system. And there's no reason for it, because the money is in the budget. So if we are talking about how we can improve maternal and child health, one of the things we must do is to see how we can reduce the level of corruption. I'm not saying it will go completely, but we should reduce the level of corruption. It's too much. In fact, it's so bad that it is difficult to, it's not even good to know the level of corruption. Effects of economic shocks on maternal lessons from 2008 global financial. In some low, middle, and income countries, 10% decrease in GDP is linked to about 8.5% increase in maternal mortality, with adolescent mothers particularly affected. So if you find that there is decrease in GDP, the maternal mortality will increase by about 8.5%, and it could be more depending on where you are. 5% reduction in GDP per capita in 2020 was estimated to result in additional 282,000 deaths in children under 5 in 2020 in about 129 low, middle, and low middle income countries. In Portugal, 2007 to 2014, a 25% rise in low birth weight occurred alongside the reduction of GDP, health spending, and social support, impacting especially on children of migrant mothers. So you can see the effect of economy on growth and development of children. Well, in Greece, one of the hardest hit European countries during the 2008 financial crisis, GDP declined by about 15% from between 2008 to 2014. Stillbirths among under 25 increased by 42. Under 5 is stillbirth among women under 25 increased by 42%. Preterm deliveries rose from 8.1 to 12.7, and low birth weight increased from 6 to 11%. And then the mean birth weight dropped by 64.4 grams. Now, this is the impact of global financial crisis on low birth weight in Portugal. A global financial crisis was associated with significant increase in low birth weight, particularly among infants of non-Portuguese mothers. Those are the migrants. Expected increase is in need during the Great Recession and worsening maternal and child health outcomes and disparities. So there's nothing good about depression. In fact, the effect of depressed economy will increase the maternal morbidity and mortality, and then child deaths. Next, food for thought. Let's have some food for thought. Let's ask ourselves, what impact is the current economic crisis in Nigeria likely to have on maternal and child health, especially for the poorest and most vulnerable groups? How well are current health financial system in Nigeria well placed to respond to the needs of women and their children with the current economic decline? I mean, we're just saying the obvious. I'm not expecting you to answer any question here, because these are clearly obvious indicators that things are not doing well. What can be done to mitigate the impact of economy on, now we're talking about global health problems requiring local solutions, enhanced surveillance, efficient monitoring and surveillance system. Again, even at that, we try to pad figures. I'm a member of the IGFP. IGFP is an independent judging panel of the National Primary Healthcare Development Agency. And when we were trying to assess performance by states, there were attempts to pad the data, and we refused. People didn't take it lightly, but we stood our grounds. So because you have to get prizes for this, you have to track indicators to see facility-based delivery, low birth weight, weight for height, and then better collection of and analysis of data, like I said. And then, of course, we need to disaggregate data so that we can keep to the trends and know the trends of the growth and development of our mother and the babies, particularly the babies. Increased maternal child health investment, that's performance-based contracts, public-private partnership, resource efficiency, optimized volume and cost of maternal child health resources to be used. Now we have to invest in maternal, neonatal and child health rates. We have to increase the investment so that we can reduce the burden of short-term adverse outcomes, such as maternal mortality, neonatal deaths, and stillbirths. Intervention to promote early child health and development. Again, we need to do that. We need to promote early child. But then, if you are not eating well, I don't see how well the child health can be properly promoted, because infections and the rest will come in, now malnutrition, kwashiorkor will come in, and deaths. Social Protection Initiative, you know there is what they call CCT, that is conditional cash transfer. I don't believe in those things, but this is being done. Social health insurance should be done, that is okay. Subsidies, voucher system to help cope with the escalating out-of-pocket expenses. If these things are done properly, they may probably help to reduce some of the burdens that we have. Community-based intervention we have to promote prevention, ownership and sustainability, and donor coordination. Again, donors now are not as, they are even tired of Nigeria, because they find that when they give us money, we don't use the money properly. So many of them are reluctant, and they want to work directly with the community, but as you know, the government will not allow that. Greater reliance on clinical knowledge, clinical judgment. Again, you find that many of us, we use technology instead of using our skills, our knowledge and skills. Before you talk, when you cough, they say go and do ultrasound. When you do, they say go and do. No, that was not how we were taught. Yes, you can have ultrasound and the technology to improve your diagnosis, but it shouldn't be a primary thing. I used to tell people I had diagnosed 2 cases of diabetes with my nose. That is the way we are taught. I used my nose. Somebody who came to see me, and then I got close to him as he was talking, and I found that there was acetone breath. And I got close. So after that, I said, please go to the clinic and go and do your blood sugar. You know that that person didn't come back, was admitted immediately, because the blood sugar had gone very high. I didn't have any instrument, but we were taught to use our eyes, our ears, and our noses. So there is no such a thing anymore. We will talk, they say, go and do ultrasound. You do this, you don't do another. And the main motive of those is profit making. Is profit making, because you need to use your clinical knowledge and skills to be able to treat some cases before you then refer them for technology backup. We are to develop appropriate cost-effective protocol for management and prescribing of generic drugs that are cheaper. That is true. You have to we were told that we should prescribe drugs in generic form because they are cheaper than branded ones. Unfortunately, many of us don't know that. We have to improve efficiency by reorganizing service delivery, strengthening our primary health care system and appropriate referral system. Again, the issue of primary health care cannot be overflowed. Primary health care system, maybe in places like the Southwest, Lagos, maybe River State, or so very few states. Otherwise, primary health care is dead in many states of the country. That is the truth. In fact, in some parts of this country, the buildings are used to store grains, unfortunately. And they keep on building without equipping this. So, and of course, there are no workforce. The chew, many of them are not even there. Even if they are there, they only go to collect money, the salary at the end of the month, which is very sad. I don't know how we can overcome this. I hope one of you will become president of Nigeria to see how we can improve on the primary health care system, or governor. Even governor, if you not, if governor is not even know, a governor can change so many things in his state. Just like Zulum, Professor Zulum is an engineer. Despite the crisis in Borno State, he keeps on doing so many things that ordinarily, even all those where there are no Boko Haram and the rest, will not do. So such people can be looked at and see how well he can continue to help Nigeria. Because Nigeria, we need a lot of support. Now let me just go quickly, the recommendations very quickly, so that we can finish. Next. Yes. Now, we'll talk about how do we sustain maternal and child health care in challenging economy. One is to integrate services. We talked about this before. We have to integrate services within the system. Instead of having this separately, we need to integrate the services. In that case, we'll have fewer number of staff that will look after many more cases for you. Now, issue of tax shifting and tax sharing. I'm one of those who do not believe in tax shifting. It's not tax shifting, it's tax sharing. As a gynecologist, I will not stop, if I say a nurse should set up drip, I will not stop setting up drip. But if I can train him or her to set up drip. But when you say tax shift, it means that you have shifted your IV fluid to the nurse. Or you don't take delivery anymore. The nurse or midwife will do it. No. And I've argued it before the WHO, even Sogon, that we shouldn't be talking about tax shifting. We should be talking about tax sharing. And I hope that many of you will join my group so that we can ward off this tax shifting. Because we are not doing any tax shifting. We are doing tax sharing because of the fact that we need lower level of health workers to support what we are doing. Community engagement is important. We'll be talking about that. Community support in some communities. They take over the running of their primary health care facilities and monitor it, even employ staff. Public-private partnership, again, these are so many issues. When you talk about public-private partnership, the private people, their primary objective is what? Is profit. So you have to be very careful. I think the only place that I see that this works very well is in the laboratories and radiological diagnostics. I think those are the areas that can work very well. Technology utilization by using mobile health technologies, telemedicine, and electronic health records, which I think many of these teaching hospitals are using electronic health records, but it has its own problems. And we need people who can maintain the system. We also need to prioritize preventive care. We have to focus on immunization, family planning, antenatal care. Reduce antenatal care. We have to have antenatal care to reduce costly complications. Family planning, immunization for children, so that we can reduce capacity development. There is no replacement for that. We must build capacity. We must continue to build capacity. There is no replacement for that. Efficient use of resources, optimizing use of available resources like leveraging the existing infrastructure in terms of equipment maintenance and timely replacement. Unfortunately, we failed in Nigeria on this. We cannot maintain our equipment. We don't think that we should maintain our equipment, and that's not good enough. And we have to advocate for policy support. We have to push for policies that support maternal and child health care, like increased funding, family planning subsidies, and tax exemptions. We have to monitor and evaluate. There is no doubt about that. Community-based initiatives support initiatives and grassroots organizations, leverage on global partnership. Partnership works. In conclusion, economic crisis heighten risks for adverse maternal, neonatal, and child outcomes. Urgent need for mechanisms to shield vulnerable groups, especially women and children and infants, from economic fluctuation to ensure continuity in care and support. Previous crises provide insight for policy review so that we can plan for the future. Investing in maternal, newborn, and child health is essential for economic stability and growth. Now, the issue of COVID, conflict, and climate change have compounded many of the issues. So it's not been easy at all, and we all need to go back and continue to review this. And like I said, let's try and see how we can help our communities. It's very, very important. Those who indulge in prayers, please, if you are talking to your patient, talk to the patient so I can understand that prayer alone does not work. So they should not go to prayers. But what about the economic issue? They don't have money, so they can't go to the hospital because of the cost of care in Nigeria. Of course, we should have been talking about National Health Insurance Authority, but what's the percentage of Nigerians that invest in National Health Insurance Authority? So, ladies and gentlemen, I wish to thank the President of Sogon and ESCO and the LOC for giving me the opportunity to present this. Thank you very much, and God bless.
A standing ovation for Professor Uja, please. Standing ovation for Professor Uja. Please clap for Professor Uja, please. MNI. We are very much behind. Sit down. We are very much behind schedule. We are moving straight to the next on the item, induction of new members. That's why I put them all together.